Welcome everyone to Conversations in PAH, an expert discussion on clinical updates and treatment options in PAH. And today we're going to talk about what's new in pulmonary hypertension, guidelines and evidence for improved clinical care. My name is Ron Udiz. I'm a cardiologist and I run the pulmonary hypertension program at Harbor UCLA Medical Center in Southern California. And I'm pleased to be joined today by Dr. Marc Humbert, who is a professor of respiratory medicine at the Paris-Saclay University and director of the French Reference Center for Pulmonary Hypertension in France, as well as Marion Delcroix, professor of medicine and respiratory physiology at the University of Leuven and Kortrijk, and head of the pulmonary vascular disease program there, an intermediate respiratory care unit. Today, our experts will be discussing three topics. The first one, the 2022 European Society of Cardiology, European Respiratory Society Guidelines for Pulmonary Hypertension. The next, emerging evidence from the European Respiratory Society and CHEST meetings. And the last, real-world PAH registries. What do they tell us? There are registries from the US and from abroad, and we'll again have experts weigh in on how to use those clinically. Our learning objectives today are to appraise the changes of the 2022 ESC ERS guidelines for the diagnosis and treatment of PAH, to identify ways to implement findings from clinical trials and recommendations in the ESC ERS guidelines. We'll discuss strategies to promote awareness of the changes in the guidelines for managing patients, and we'll describe important research highlighted at the ERS and the ACCP, or the CHEST annual meeting recently from 2022. We'll discuss the clinical implications of this latest evidence for the care of PAH patients and examine the validity and utilization of real-world registries, along with the benefits and limitations of those registries. And finally, we'll appraise the value of patient registries collecting observational data and advancing knowledge to improve PAH care and outcomes. So we're going to kick off with a discussion, hopefully a lively discussion, about the 2022 ESC ERS guidelines for PAH. Marc, as the current ERS president, can you provide some background to the process and the task forces and the timelines that you were part of in developing those guidelines?
Well, thank you, Ron. Thanks for the invitation. And indeed, the European Respiratory Society is a very structured organization with three main pillars: education, science, and advocacy. And clearly, when one wants to develop a guideline or update a guideline, there is a process. And the process is very formal. You need to put together an application. And for the application, we wanted, with Marion Delcroix and Stefan Rosenkrantz and all the colleagues in the panel, we wanted to have joint guidelines between European Society of Cardiology and European Respiratory Society. And that was what we proposed. And because of this joint guideline process, we had a very interesting methodology with two ways of rating the evidence. The classic European Society of Cardiology rating with class 1, 2A, 2B, and 3, and level of evidence ABC, but we also used the most classic grade of evidence with PICO questions, 4 more questions, and rating the evidence according to the grading system, the grade system. And this is a reason why in the guidelines you have many ways to appraise the evidence. The most classic one is 1, 2, 3 with the level of evidence ABC, but for 4 discrete questions, which were regarded by Marion, myself, and Stefan as very important, we use a grading system, which is a little bit more stringent in terms of evaluating the quality of the evidence. So the formal process was rather simple, rather straightforward. We had a lot of people in the panel, including patients. That's something we really wanted. So we had a lady patient from Italy and a male representative from Hungary. And what is beautiful in that guideline is that we covered the whole spectrum of the evidence, including the patient vision and the pulmonary hypertension vision. So that's in brief what we did.
Thank you, Mark. Mario, welcome. Can you explain how the hemodynamic definition of pH has changed and what data propelled these changes?
Well, so we have a few changes in these guidelines when you compare with the 2015. We had first another cutoff for the mean pressure, another cutoff for the PVR, and also we reintroduced the exercise pulmonary hypertension concepts. And so how to justify that? Well, it was a long process from 2015 to now, which passed through the World Symposium on Pulmonary Hypertension, whereas there was a proposition to decrease the cutoff value for the mean pulmonary arterial pressure to above 20. This proposition was based on mainly the work of Greg Maron on the prognostic impact of this pulmonary arterial pressure. First, we also come back to old data from Gabor Kovacs, who showed that the mean pressure, which is normal, is 14 plus 3 standard deviation. And so when you add 2 standard deviation, you come to 20. So this is a normal value. And then the prognostic impact is very important, where you see then when the pressure increase above 20, you start to have an impact on the survival independent of the cause of the pulmonary hypertension. And this was two important arguments to accept the 20 millimeters mercury as the upper limit of normal. And then we had this PVR change. For the beginning, it was more than 3, more or equal than 3. But again, data came showing that the cutoff value is more in the range of 2. And then you have an impact on the survival again when you are above 2 Wood units. So concerning finally the exercise pulmonary hypertension, again, that was shown that the slope of the pressure-flow relationship is very important. And you start again to have an impact on survival when you have more than 3 millimeters mercury per liter per minute in this slope, while a normal slope is 1 and can go up to 2, depending from the age of the patient. So we had very good hard data showing that these new cutoff values are correct.
Thank you, Marian. Mark, could you tell us what's changed in the classification of pH over time? How has that evolved?
Yeah, thank you, Ron. Indeed, the classification has evolved a bit, but it is a modification of what was already very well known. And we maintain, of course, the 5 major groups, group 1 corresponding to pulmonary arterial hypertension. And the only change is that we introduced the concept of idiopathic pH patients with or without acute response to vasoreactivity testing. This derives from the last World Symposium, and we consider that it was the right place to put this response evaluation in the group of idiopathic patients, even though some patients with heritable familial pH and people with drug and toxin-associated pH can be responsive to acute vasodilator challenge. We also identified pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis as a subgroup of group 1 pulmonary arterial hypertension with features of venous and or capillary involvement. Then the group 2 pulmonary hypertension associated with left heart diseases, by definition the largest one, the one with the most important number of patients. And here the subcategories are in line with the classification of heart failure. So pulmonary hypertension due to left heart disease. The first subgroup is heart failure with preserved ejection fraction, then patients with reduced or mildly reduced ejection fraction. Then we have the patient with valvular heart disease and the patients with congenital or acquired cardiovascular conditions leading to post-capillary pulmonary hypertension. Then the group 3 is very important in terms of numbers. It's pulmonary hypertension associated with lung diseases and or hypoxia. And here we have separated obstructive lung disease, mostly COPD with emphysema. Restrictive lung disease, mostly idiopathic pulmonary fibrosis. And then the patients with combined pulmonary fibrosis and emphysema. Hypoventilation syndromes are maintained as a cause of pulmonary hypertension associated with lung condition. And we have, of course, the group with hypoxia due to high altitude and also the lung disease due to developmental lung disorders. So the simple sleep disordered breathing have been removed from the classification. We maintain only the patients with hypoventilation syndrome, which can be treated with ventilation support. Then the group 4 is super important. It's pulmonary hypertension associated with pulmonary arterial obstruction. The most important subgroup here is chronic thromboembolic pulmonary hypertension, which is a treatable condition, and we will certainly discuss that further later on. And then the group 5 is pulmonary hypertension with unclear or multifactorial mechanism. And here you have an array of hematologic, systemic, metabolic conditions which have not changed since the last guidelines, but we have introduced chronic renal failure with or without hemodialysis. We have introduced pulmonary tumor thrombotic microangiopathy, and we have introduced fibrosing mediastinitis. So the classification is really made for clinicians, and it's really made for clinicians to have a clear vision of what is the main mechanisms leading to pulmonary hypertension, and according to the mechanism, there will be a treatment strategy. So the treatment strategy for group 1 PAH is based on medical therapies and lung transplantation. For group 2, it's treatment of the causal disease. And for group 3, it's also treatment of the causal disease. You have some emerging PAH drugs available for group 3 pulmonary hypertension with approval in the United States, not yet in Europe. And for group 4 pulmonary hypertension, obviously surgery, angioplasty, and medical therapy are very clearly indicated in these people with a treatable trait. For the group 5, it's more a la carte with optimized treatment of the underlying disease.
Thank you, Mark. I would imagine, given the previous discussion we just had on the revised definitions, that being of a lower mean pressure and a lower PVR, as well as exercise-induced, and harmonizing that with the differential in the classification can become a little bit more difficult because, for example, somebody that might have multiple comorbidities who has a mildly increased PVR output, or a mildly increased pressure output ratio would be difficult to definitively classify at that low end, if you will, of the spectrum. Do you find that that these types of patients are becoming more common now that the lowering of the parameters has been effected?
Yeah, indeed. No, it's a very, very important comment you just made. Clearly, lowering the pressure and lowering the resistance, the message is to be aware that pulmonary hypertension matters. It doesn't mean that you need to treat all these patients at once, but you need to identify them as being affected by a hemodynamic compromise, which might influence their future outcome. For example, in patients with group 2 and group 3 pulmonary hypertension, the vast majority have very mildly elevated pulmonary pressure and pulmonary vascular resistance. We don't push for treating these patients with a specific drug, but we say, well, keep an eye on these patients, optimize their treatments, and try to keep an eye and follow them up. For patients with group 4 pulmonary hypertension, well, the lowering of PVR and mean PAP indicates to be more aggressive in terms of surgery or angioplasty or combined treatments. For group 1 PAH, of course, we are very, very careful, very careful. We never consider that a patient with borderline elevation between 21 and 25 and PVR between 2 and 3 are candidates for approved drugs, because all the approved drugs have been tested in patients with the older definition, and we advocate very much for new randomized control trials for these patients. The last thing I wanted to say is that even in patients with marked elevation in pulmonary pressure and resistance, you need to be aware that patients with multiple comorbidities, especially when they have comorbidities reminiscent of possible diastolic left heart dysfunction, you need to be more careful when you treat these patients with PAH-approved therapies. But I think we will discuss that more in detail later on.
Mariam, would you agree that the bulk of the physicians and treaters, at least in the European Union, support what Mark said in terms of not treating patients with group 1 in that borderline zone until we have more data, or at least not treating automatically until we have more data?
Yeah, clearly, because we have no labeling allowing that, and most of the countries are very regulated in terms of prescription of the PH drugs. So that's clearly, and this is also very clearly explained in the guidelines.
Thank you. Can you guide us, can you guide the audience through the diagnostic algorithm, the updated algorithm that came from the recent guidelines?
Well, you see, there is a big change in comparison with the previous guidelines, where we were more looking at the exact cause of pulmonary hypertension at the end of the graph. Here, we try to follow more the patient's path, and the patient's path starts at the GP. And so we wanted also to sensibilize the GP that we have to look at the cause of unexplained exertional dyspnea. So you see, it's not only an algorithm for suspected PH, it's becoming also a way to investigate patients with unexplained dyspnea. And so the GP, of course, is a key player there. And he will be the one who sends the patients to a pneumologist or a cardiologist, and where the second part of the assessment will be done. So we also emphasize some warning signs. So we want, of course, that also GP are aware that the patients who have regular syncope is a patient at risk and should be sent to potential specialized centers. So we have this first approach by the GP, then we have the specialists who are involved. And one of the crucial part of this step, so step 2, the detection, is that we have, of course, the echocardiography in the hands of the cardiologist, but we also encourage an important cross-referral and interaction between the lung specialist and the heart specialist, because we know that is a moment where the patient gets a bit lost. The pulmonologists do some examination, and then they don't interact very intensely with the cardiologist, and then the patient spent weeks and months there in this intermediate state. And so this is one of the most important change in the diagnostic algorithm. The next step is then to be based on the PH probability from the echo to decide if you have a patient with intermediate high risk to refer the patients to a PH centers. If it is a low probability, then we encourage to look at other causes, also to follow the patients to see if the pulmonary hypertension becomes more severe, and also take into account the risk factors for PH and CTEPH, like the comorbidities of systemic sclerosis or a history of pulmonary embolism, for example. So there are really 3 steps which are really linked to the patient's path.
Thank you. You mentioned echo as the determinant of probability, and I know that the guidelines have recently been updated to discuss the probability of echo and how to use the echo findings. Mark, could you just talk a little bit very briefly about the figure, or if you will, set of 12 figures that help the reader figure out how to determine the probability or likelihood that PH exists?
Yeah, indeed. This is a beautiful multi-panel figure, and I know a lot of energy has been put by cardiologists in the making of these panels. Well, the key message here is that you have a series of very important steps, and you need to measure the size of the right ventricle in the parasternal long axis view, but also in the 4-chamber view. You need to analyze the flattening of the interventricular septum. You need to check the size of the inferior vena cava. You need to measure the right ventricular fractional area change. You need to measure the TAPSE. And a very important thing we have added in the guidelines is the TAPSE over PAPSE ratio, which is predictive of future outcome. And of course, you measure the right atrial size and the peak tricuspid regurgent velocity. I think the message, I'm not a cardiologist myself, I'm a respiratory doctor, but the take-home message here is that we don't want to see only the TR jet velocity measure. That's not what we want to see in isolation. We want to see the full picture, and with good cardiologists like you guys, we can have a broad analysis of not only the TR jet velocity, which will help estimating the pulmonary artery pressure, but the systolic pulmonary artery pressure. But we need also to know more about the right heart function. And I think that's the key. We put a lot of figures and a lot of words in that figure in order to tell the community that the echo is a very important tool, which should characterize the patient more than only giving an estimate of the pulmonary pressure.
Marianne, would you agree with the concept that a PH treating specialist at a specialty referral center needs to know the echo parameters and assess the echo in many ways better than a referring cardiologist for that same patient? In other words, you have to take charge as the PH specialist and assess the echo yourself, as opposed to reading the report from the cardiologist who may not be familiar with PH.
Yeah, I completely agree with what you say. I think as PH specialists, even if we are pneumologists, which I'm also am, I think we are very familiar with these signals. We have access to the picture in most of the hospital. We have this picture that we can access to, and frequently we also don't look so much at the measure, but just looking at the picture, and you know that eyeballing in this disease is very important. But we thought we were very much inspired by the ERS Guidelines for PE, where they put this all together, and I think it's very nice to have a place where you see the global picture of the disease. So important that everybody learns to look at these images. Of course, you will tell me as a cardiologist that there are other signs that you want to have more. And I think if you look in the supplement, for example, you will have a table where additional parameters are described, but this is then for the specialist.
Thank you for mentioning that supplement. I think I forgot to mention that. I'm extremely happy to see that the catheterization now has a Class 1 indication, officially and formally. Could you just talk a little bit about this new addition to the guidelines that help the non-expert understand the importance of the catheterization and what the numbers should be?
Yeah, of course. Indeed, the Class 1 is logical because the condition is defined by invasive measures of the pulmonary pressure. So that was, I think, absolutely mandatory. Now we clearly state with a 1B level class of recommendation and level of evidence that right heart catheterization is recommended to confirm the diagnosis, especially for group 1 and group 4 pulmonary hypertension, so pulmonary arterial hypertension and chronic thromboembolic pulmonary hypertension, because in those two instances, there will be a clear treatment decision based on the evidence of the pulmonary pressure measured by invasive right heart cath. So in the patients with suspected or non-pulmonary hypertension, it is recommended to perform right heart cath in an experienced center. So in the community, some people want to try, I mean, we discourage that. We think it should be done in a place with knowledge on pulmonary hypertension, because there will be some also additional tests we are going to discuss in a minute. And when you do a right heart cath, once again, you don't only measure pressure, you measure a full spectrum of information. And I will briefly mention them because all of them are important. So the right arterial pressure is so important to identify whether the right heart is coping with the elevated pressure or not. Then you have the pulmonary artery pressure, the systolic, the diastolic, and the mean. Of course, the wedge pressure, which will tell you if the pulmonary artery, if the pulmonary hypertension is pre or post capillary. Then the cardiac output, of course, which is absolutely mandatory to calculate pulmonary vascular resistance. Of course, we want the mixed venous oxygen saturation and the arterial oxygen saturation and the systolic blood pressure and the heart rate. So at the end of the day, we have not only one measure. It's like for the echo comment. We want the full spectrum of information, and then you will be able to calculate the pulmonary vascular resistance, the cardiac index, the stroke volume, which is so important, and the pulmonary arterial compliance. So at the end of the day, right heart cath is a magic tool for assessing and confirming pulmonary hypertension. So the full set of hemodynamic parameters should be done following standardized protocol. And a patient undergoing a right heart cath should have a full report, which will inform not only the doctors in charge, but also the future teams which might have to consider this case.
Thank you, Mark. Could you briefly comment also on vasoreactivity testing and the fact that now it is part of the algorithm in the catheterization, but maybe just tell me, are we still talking about vasoreactivity responders who should still primarily be initiated with calcium channel blockers according to the guidelines?
Yeah, indeed. We don't test acutely all the patients with pulmonary hypertension. We do consider that vasoreactivity testing is important in people with idiopathic, heritable, familial, and drug or toxin associated PH. In those people, we do test the patients usually with an inhaled drug, either inhaled nitric oxide or inhaled iloprost, or intravenous epoprostenol. And we have a very clear definition of what is a responder. A responder is a patient who has a drop in mean pulmonary artery pressure of more than 10 millimeters of mercury while being tested acutely to reach a value of less than 40 millimeters of mercury with increased or unchanged cardiac output. And these people will be the people who will be invited to be tested with high-dose calcium channel blocker. And we don't treat all the patients with calcium channel blockers. We limit that to the idiopathic, heritable, and drug and toxin-associated PH who have characteristics of acute response. And then these people will be reassessed regularly every 3 to 6 months to reach a near normal value when we will reassess them in the long run. So it's only 5 to 10% of these patients who do respond, but they are good patients for long-term outcomes with simple drugs.
Marianne, let me just ask you briefly, if you see a patient who is responsive, does it matter whether or not their other features of their disease are high or low risk? In other words, it's probably unlikely that you're going to see a very high-risk patient who is vasoreactive because by definition, they are usually more advanced. But if you see patients like that, how do you approach the initiation of therapy? Do you just...
That's a very good point, because we had this discussion during the task force meeting, because some of us thought that if you have a patient with a cardiac index of lower than 2.0, that it could be even dangerous to do a reversibility testing and to start with calcium channel blockers. But at the end, I think that we reach a consensus that even in patients with a very poor hemodynamics, it is so effective therapy when you give it to the adequate patients that we shouldn't, we should do it in all patients with PAH, idiopathic, heritable, or drug associated.
In any case, Mark, would you agree that that should be done in a specialty center only?
Oh yeah. Mario and myself, we are strong advocate for that, and it's always a pity when the patient has a right heart cath and no testing. That's because we have to repeat it. The second thing, Marion was very clear, and it was your question. It should be done in stable patients. The patient should be stable, and it's done in experienced centers.
Okay, let's talk about the. Once we've gotten our diagnosis, the risk stratification for patients. Initially, in the old guidelines, we had low, intermediate, and high risk classification. And now we talk about after initial diagnosis and after treatment for follow-up, there are 4 categories, splitting the intermediate into 2.
Indeed. So clearly, there is room for refinements and improvements of the guidance for the best treatment of patients with group 1 PAH. So here we discuss group 1 PAH, and at the time of diagnosis, we maintain the 3 strata model, low, intermediate, and high risk, because depending on the subcategory in which you will classify the patient, you will have an initial therapy which will be adapted to the severity. And here we have available data, including hemodynamics, and the patient should be clearly identified as low, intermediate, or high risk, and the initial therapy will be decided at that stage. But at follow-up, we thought that it was very important to sub-classify the patients who have intermediate risk into 2 discrete groups, intermediate high or intermediate low risk, because indeed, and we learn once again, as Marion said, from the pulmonary embolism guideline, the vast majority of patients with PAH group 1 on therapy, they are intermediate risk. But there are 2 different faces of the coin. You have the intermediate low risk, who may have a good long-term outcome and in which you have room for adapting the treatment with oral drugs and refinement of the treatment. But you have also the subgroup with intermediate high risk, which is less simple, and in which you really need to consider transplantation not too late and consider parenteral prostacyclin therapy. So at baseline, we have the 3 categories which are based on clinical signs, signs of right heart failure, exercise capacity, and biomarkers, and echo, MRI, and hemodynamic parameters. And thanks to the many parameters you measure at baseline, you can have a good idea of the low, intermediate, or high risk. At follow-up, we have simplified enormously the follow-up. We don't say that you don't have to perform right heart cath at 4 to 6 months of therapy. In my center, we still do it. But we do say that with non-invasive assessment of functional class, walk distance, BNP or NT-proBNP measure, and the subcategorization of these patients in 4 different strata, you can have a non-invasive flavor of whether the patient is in the right track, low risk, in the wrong track, high risk, or in between, but in between means 70% of the patients. So it's better to know if it is intermediate low risk with more room for intervention versus intermediate high risk, where you really have to consider action and more invasive, aggressive treatments.
Excellent. That's, again, an area for experts, I hope only experts, that need to be involved in the patient care at the follow-up for those assessments. Let's jump to the treatment algorithm. What's new in the guidelines in the treatment algorithm? Mariam?
Well, you see that the decision process has changed again a bit. So you have these patients for the first, we know that the most available evidence we have is directed to patients with idiopathic heritable and drug-associated PH and PH-associated CTD. So this is the central part of the guidelines, and we have additional paragraph on specific forms which have a special management. You will see that in the guidelines. So first, this vasoactivity testing in the patients we described already, and then the general measures, which are also a bit changed in comparison with the previous guidelines. For example, concerning the anticoagulation, which is not anymore uniformly advised in this patient's population. And then you see the first step is what is cardiopulmonary comorbidities. So we have this division now where we have the patients without cardiopulmonary comorbidities, and we follow a very strict algorithm, and then we have the one with cardiopulmonary comorbidities. And this is something which rose a lot of discussions because we have, of course, in these cardiopulmonary comorbidities, two sorts of patients, the one with more the pattern of heart failures with preserved ejection fraction or the risk factors for that, and the patients with more lung disease with very low diffusion. And it is clearly a work in progress because we need to better define what are these comorbidities, how severe they are, but we wanted absolutely to start this discussion because, as you see, with aging population, we have more than 50% of the patients, perhaps even 3/4 of the patients who have these comorbidities. So this was a very important part. Then we have this first risk stratification that Mark alluded to with the 3 risk categories, and then we decide the treatment in function of these 3 risk categories, reserving the intravenous of subcutaneous parenteral prostacyclin to the patients with high risk, all the other benefiting from combination therapy with an ERA and phosphodiesterase 5 inhibitors. And what is again a very important addition to this algorithm is the 3 to 6 months evaluation, follow-up evaluation, which is crucial because we know that at this stage we can already see in which direction our patients are going. Will they have a favorable outcome, or will they still not be at goal? And this is why we use then these 4 strata, because you have seen that also the cutoff value of the mortality have changed in the guidelines. So we know that patients with high risk, they have not more than 10% mortality in 1 year, but more than 20% mortality in 1 year. And the one which at follow-up remain in the intermediate high risk, they have still 10 to 20% mortality. So it's still a very, very important decision to do at follow-up for these patients because we still consider them at very high risk. So this is the main changes in the therapeutic algorithm. Follow-up is very important, and then to see if they have additional comorbidities which have an impact on the tolerance of the treatment. This is most important point. Then we think that these patients with many comorbidities, perhaps they respond a bit to the treatment, but anyway, they have more side effects and they more frequently stop this treatment. And that's why we want a cautious approach.
Excellent. We don't have time for the audience to go through all of the recommendations for escalation of treatment and add on. Suffice it to say that there are a long list of recommendations, which is based on class and level of evidence that need to be scrutinized by every expert, anybody that's treating these patients. You mentioned, Marianne, follow-up. Mark, can you just talk briefly about the follow-up and the importance of the interval between visits when you're seeing these patients?
Yeah, indeed, you made it very clear that these patients should be followed by experts, and in Europe, it's really very important, and I know you do share the same vision. At baseline, you need a full set of parameters completely evaluated with no missing values. So everything should be available at baseline. including right heart cath, of course, because in group 1 PH, you need to have a definite evaluation of the pressure and resistance and wedge pressure. Of course, you need also to know the walk distance, the BNP level, the echocardiography and quality of life parameters. And in some centers, the CPET, I know you are really interested by that, it can give an additional information. Then every 3 to 6 months, we do see the patient in the clinic and we repeat at least the non-invasive measures. And we do repeat the invasive measures if the patients are really deteriorating a lot, or if the invasive measure will give you a decision for treatment. But each time we follow the patient, the least we can do is a non-invasive parameters to be able to risk stratify the patient in the 4 strata restratification instrument. It will help you to decide whether the treatment is adapted or whether it should be modified.
Thank you, Mark. As we're getting close to the end of our discussion, there are some new guidelines in the management of CTEPH. Mariam, could you briefly cover the important points you want to make about that?
Mm-hmm. So what we wanted to point out in these guidelines were that we have 2 flows of patients coming to the diagnosis of CTEPH. We have the one who are discovered during the workup of pulmonary hypertension, where perfusion imaging is crucial to be done in this workup. And then we have a second group of patients who are coming from the follow-up of acute PE and who have persistent symptoms. And also by these patients, we recommend after 3 to 6 months to have an investigation, including perfusion imaging and echocardiography. Echography, again, should be intermediate or high risk. And then when you have patients who don't show pulmonary hypertension at echo, it is important also to, if they have symptoms, to document perhaps pulmonary hypertension at exercise by echo or by cardiopulmonary exercise testing. And for these patients, we recommend that they are also sent to the CTEPH centers to be investigated, to look at more precise imaging with CT, looked by expert radiologists, perhaps with digital subtraction angiography, and with the right heart catheterization. And then in combination, we go to the multidisciplinary team to evaluate what is the best treatment strategy for these patients. And what is also new in the guidelines that the balloon angioplasty have been upgraded to 1B recommendation, while it was previously something which may be done. Now it's a very important part of the treatment. There are some combinations, so we are going for multimodality therapy in order to do the best we can for the normalization or improvement in the hemodynamics and the symptom of these patients.
Great, Mariam, thank you so much. As our final question, I'd like to hear just briefly from both of you. What do you think are the strengths and weaknesses of these guidelines? And I think we should focus, we know the strengths, we obviously have just talked about all of the new important class of guidelines, but what should we be worried about in terms of the guidelines, and where should we exercise caution? Mariam, we'll start with you.
That's a difficult question because we are still close to the process, and it's difficult to criticize your own work. Anyway, some things we are aware that bring some confusion are the comorbidities. This is something where people will have perhaps even more difficulty to classify patients as having PAH with comorbidities, and then group 2, group 3. This continuum is still a limitation of the guidelines, but I think we were not able, we have not the data to do much better at this stage. For the other, of course, there are still a lot of recommendations which are based on expert opinion. We have improved, so now I think more than 1 in 4 recommendation is based on some evidence, but there is still a lot of work to do to have more evidence in the recommendation which are there.
Mark, anything to add on that?
No, it's a multidisciplinary exercise. We are really fortunate to have so many people from different backgrounds working together. We had the patient voice, and it was really important to have the patient voice, and it was very well heard. And what Marion just said, it's a work in progress. I mean, we maybe went quite far for some aspects like the comorbidities, but it's a kind of warning also. We need to consider these patients who represent the vast majority of patients in many centers, whether we do consider them the right way or not. So the next guidelines will certainly focus on more questions, more PICO questions, and certainly the multimorbidity patient will be part of it.
Thank you. I won't try to actually summarize the guidelines, but I will just highlight some of the things we talked about to close out this talk. pH is defined now by a mean pressure of greater than 20 rather than 25, measured during right heart cath, which is mandatory for the diagnosis. However, the PVR cutoff is now 2 Wood units down from 3. Despite the change in the hemodynamic definition, the threshold for TR velocity on echo is still 2.8 meters per second. TAPSE SPAP ratio has been added to the list of markers, and of course, it's a comprehensive integration of all the echo findings, not just these two. Idiopathic pH is now substratified according to vasoactivity response, and the new treatment algorithm now has 4 risk strata when you follow up the patient after initial treatment. So I thank you very much for joining us with this comprehensive, detailed, microscopic view of the new guidelines for the rest of the world. And again, appreciate all of your efforts for you and your task force members. Stay with us. We're going to next talk about what's new in guidelines and evidence for improved clinical care from the ERS and CHEST meetings coming up.